Hello, good afternoon. Victor, and Vagner. Thank you for being here. This is a very important topic for the future. The future that we always think it's just way too far into the distance, but it's just around the corner. Genetics is a good predictor of what's next. We're here to hear whatever you have to say about your experience. But this is how I see this panel, just a frame so that we can discuss these things. How can we transition from an industry that is disease focused or something that is focused on the diagnostics per se, an industry that is looking for diseases rather than health? When we talk about genetics, prediction, sensors, and we think about a different health system, something that will happen before the disease comes, if it comes at all. So what's your take on this major change? It's not a matter of a new technology. It's to change the rationale behind the health system. This is very important. And there's something else. Whenever we talk about genetics, it's not a matter of having a test and have a result. We need people that know about the subject to provide that feedback to patients. I think it has to do with communications, both on prevention, which is the topic, and also the individualized treatment. And the third aspect I would like to touch upon during our conversation is how we're going to interpret all this new technology. We look at technology today, making comparisons, making head-to-head comparisons, taking something we know and then compare with something new. But when we talk about populations, these are going to be more and more personalized interpretation. Treatments will be customized. How are we going to make that kind of transition as well? And I would like to use your own experience, your own backgrounds. I'll give you 10, 15 minutes each, and then we can move on to the Q&A session, to the debate portion of our conversation. So Vagner Simões is first. Welcome, Vagner. You have the floor. Thank you, Marta. Good afternoon. I think questions are very important. You talked about disease, treatment, genetics, counseling, giving patients some feedback. And when we talk about individualized treatment, we are touching upon a concept that has been discussed, which is precision medicine. I don't like the term because you can be very precise and still make a mistake. Precision is different from correctness. Precision can be very precise, very repeatable, but reaching the wrong spot. So I'd rather use the expression personalized medicine, which is focusing on the individual and their own personal characteristics. This is nothing new. Socrates used to say when he talked about idiosyncrasies, individuals are unique and will respond to stimuli differently. It's an old concept, but we have been resorted to it time and time again. When we talk about personalizing and when we talk about specific characteristics, that involves genetics. It's our genome that carries that recipe, quote unquote, that makes us who we are. And we respond differently depending on the disease. They can have an early onset or a late onset of a given disease. So that's the initial step. Many diseases have their genetics mechanisms, just like cancer. Cancer is a good example when we talk about personalized medicine or precision medicine. Our cells can no longer program themselves due to a genetic mutation, and they begin to reproduce uncontrollably. In order to fix something, you have to know what's wrong, what's broken, so that you can fix it. So again, understanding the genetics of a disease, our genome, and how we are going to respond to any given stimulus, that is indeed very important. The cancer is not the only example, albeit it's the best, in my opinion. There are other diseases with genetic components. There are some rare diseases that fall into that type. Cancer, given the type of tissue, lung cancer, so we classify them based on their tissue origin: prostate cancer, breast cancer, lung cancer, etc. That may have one classification, but they are different because there's that genetic component. So two cancers are rarely alike because the alterations may be slightly different. You may be born with that kind of mutation, and that's what we call genetic or inherited cancer. That's Angelina Jolie's case, which is well known. Some mutations were detected that would increase the likelihood of developing breast cancer. So she resorted to a mastectomy to prevent her from developing that kind of cancer. So these different mutations can be inherited, and there are other mutations that can take place throughout life, because our genetics is part of what we are, of who we are, but they're subjected to the environment, whether we smoke, whether we exercise, our diet, and even our own microbiome. These are called acquired mutations that can lead to cancer. These are somatic mutations. So these are particular characteristics that you have to look into an individual, because responses will be different. People will react differently. And when you talk about how can we change the focus of our system, because today we're focused on treating the disease, but the best treatment is prevention. We all know that. But our genome can tell us a lot about predispositions. And Victor will give you a very good example when we talk about predisposition. When there's that genetic factor, hemoglobin, that can increase the likelihood of developing a tumor, we can change our lifestyle to adopt healthier habits, trying to minimize that risk. That's prevention in a nutshell. How the healthcare system can help? Will it increase costs? Yeah, it may even increase costs initially. Genetics and genetic tests are still relatively expensive, despite the fact that these costs have been coming down. However, the treatment is much more precise and you prevent unnecessary expenses from happening. Long term, it will be way more cost effective for the health system than treating the disease itself. We do have a lot of information that can be extracted from our genome. We're just scratching the surface. Yeah, we still have a long way to go. Artificial intelligence, machine learning, big data will help dramatically. Genomics is a data science. We need data in order to come up with conclusions. Today, we do have technical capacity to generate a lot of data. We need bioinformatics, computer science that will analyze data based on phenotype and phenotypical characteristics so that the geneticist can actually analyze that data and give patients some feedback so the patients can improve their habits, trying to adopt healthier lifestyles to reduce the risk of diseases. I think I've spoken way too much, but anyway, that's what I think. Oh, that was just great. That was brilliant. I remember when that story of Angelina Jolie came up, I was right there at the ANSIA in charge of coverage. The day after was just crazy. Mondays used to be very exciting. The same thing happened with that case. Our discussion revolved around cultural aspects. When you discuss a prophylactic mastectomy in Japan, it's way more complicated here in Brazil. There's that medical aspect, but there's also a cultural aspect that revolves around genetic counseling. That was another concern on our part. How can I explain that you have these X% amount of likelihood of developing that disease, but it may never happen in the future? So you have to make a decision taking these things into account. So when we talk about genetics, maybe Victor will address that. Maybe he has discussed that to a certain extent. Let me turn over to Victor Andrade. It's so good to see you. I miss you. I think Victor can provide us with real life data because I believe you have been using it for quite some time. Thank you, Wagner, Victor Muniz. Thank you, Martha. I would like to thank FIS for inviting me. We need genetics. I graduated in 1998, and I was privileged to see genetics transform the medical professions. I was trained in the 1990s to recognize tumors by sight, and I had to learn for 15 years as a pathologist to add last names from genetics to these tumors. We used to say lung cancer. That was enough. it was not that easy to separate different types of lung cancer. There was no different treatment. Many things have changed. You have to determine what the morphologic subtype is or the genetic mutations in there, because treatments are different. It's very nice to know more about stuff. Genetics came and gave us the answers. Why is this tumor more aggressive than the next? It all started with the human genome study in the 90s, and then the genomic atlases for cancer starting in 2000. CDC, these are international consortia to better understand cancer at a much deeper level. When you know these things in detail, you can personalize the treatment. If you do not know that in detail, be doing the same for everyone. We have to find ways to be cost effective. Genetics can find that sweet spot because genetics can be cost effective in some niches. Pediatric cancer is rare. It's not preventable because there are no bad habits in children. It's usually a family tragedy. More often than not, pediatric cancer is hereditary in nature. So to resort to genetics in all pediatric cancers, it makes more sense. So when you look the niches where to apply genetics first, you learn how to use it and use it well, with intent, with wisdom. It's much cheaper to resort to genomic tests when you compare the costs of the entire genome some decades ago. It's just 1,000th of the cost, a fraction of the cost. It's still expensive when compared to the health system we have in place and its economic power. Genetics is yet another piece of information in everyone's lives. But for some individuals, that's the most important information. For 5% of individuals that do have cancer, that cancer can be explained by the mutation of a single gene. A classic example is the ocular tumor, the eye tumor. The likelihood is very high. There's no point in talking about lifestyles and healthy habits. However, they have an important decision to make. There are so many other tumors that are not hereditary. They have a familiar or a family-related behavior. There's a predisposition there, but I cannot pinpoint one gene. It's a set of changes that will make that family more risk-prone. Each gene separately would contribute a little less. But when you add it all up,
I think Victor's connection froze. Did that happen to you as well? I'm back. Oh, you're back. Yes, go ahead. So you're saying that? Yes, 40% of tumors could be avoided through changes in lifestyle by avoiding obesity, smoking, alcohol consumption, and getting vaccinated. You could avoid up to 40% of all tumors, but obviously not every tumor can be avoided because there is an important genetic component to some tumors. I agree with Vagner in that genetics can be supported by deep learning, and they can help select the populations at a higher risk. I'll give you an example. There's this Canadian algorithm by McGill with an excellent performance in identifying which children should be tested. And it gets almost everyone right. and they're able to pinpoint the children that need the test and a treatment. We have recent publications regarding that. We studied, for instance, breast cancer and stomach cancer. We scanned the slide of the pathology, and we used deep learning to identify histological characteristics of tumor that predict mutations. And we found the homologous recombination features. In case of breast cancer, BRCA1, 2, and in case of the stomach cancer, instability of microsatellites. So you can use the tests more accurately, only in the people who it makes sense to use. With that, you're able to reach a better cost effectiveness for that test. In some other niches, if you expand the analysis to a population and not only to a family, you can use the argument of cost effectiveness. I've seen articles advocating that you should test every woman for breast cancer because the lives saved of the price of that would cost more than the price of the test. So Martha's question is how to bring that into a prevention setting. Everything we do in terms of oncogenetic prevention, I think the biggest challenge of prevention today is that we design protocols for the average individual. Mammogram annually, that's for the average individual. Colonoscopy, that's for the average risk of the population in general. If we start identifying risks, and for sure, a woman that's never had a history of breast cancer in the family, and she's thin, active, does not smoke, does not drink, has breastfed twice in her life, her risk is much lower than a patient with several cases of cancer in the family who's obese, sedentary, and has never breastfed. So if we add it all up and genetics, we'll be able to better define the calendar of tests for the entire population. We could create some algorithms to personalize the agenda for each person and maybe save resources. And that is a relevant subject that we could work on. The expertise of doing the test and interpreting it cannot be underestimated. You talked about interpretation, and since we have a lab here, and I also see what happens outside, I would add also the knowledge of running this test. It's not a trivial thing. Doing a genomics test, it's not enough just to insert something into a machine and get a report from that. It's not like that. There's quality control. There's important and elaborate steps involved in that process, because people frequently ask, is there a BRCA mutation? And instead of ordering a BRCA mutation, they order a complete genome, and they get a lot of things back. And that's probably too much information. And what do you do with the surplus of information? There's lots of things moving that way in the world. There are some polymorphisms that are associated with quality of life. People that are more prone to smoking, to sedentarism, or whatnot, because of genetics. We don't know if genetics can account for it all, but there's a lot still to come. The sheer amount of information is so huge that if you do not have a question before the test, you can get lost. And deep learning can help us identify the interpretation of these data that come from a complete genome test, which is something that very few people can do. And fortunately, at our lab, we can do that. To summarize, I would say that what we have in terms of prevention is insufficient. We cannot prevent everyone, and it's expensive and not effective. Genomics is helping us in that regard, but it has to find cost effectiveness niches. And in the future, I hope that data analysis and deep learning will help us further refine and make the environment of genetics more effective at pre-identifying where genomics can fit in so that we can use these resources in the right way with the right people and really benefit them. I believe in the financial balance of the system with genomics, Martha. The new technologies will be more expensive because they'll be applied to smaller populations, but they'll have much fewer side effects, and they'll keep individuals alive and productive in society. So if we do the math, from a wider perspective, I think that I'm hopeful that that will happen. I was jotting down many things that you were saying, but what you said about the niches, I think that we have to focus on that in the healthcare system, how to distribute resources across the niches. Artificial intelligence that you mentioned, and being able to redirect and reallocate resources, that was interesting. And also when you spoke about the speed of knowledge, we got a certain amount of knowledge, and then it took us decades to double down on that. And now it takes us weeks or even years to reach a higher level of knowledge. And I think that things are getting faster and faster because we learn from our own learning, and things just grow from there. I don't think we could predict the speed of this growth, even if we wanted or could. And some things stood out that probably we're not concerned about today, about diet and several different things. So we have accumulated knowledge where we want recommendations about other things, but now we get that at home through a letter that you simply open and read. So I think that we still have a lot to, not only about the best way to do things, about how to test and to examine, but also in terms of what we've been thinking about and what we've been doing, because this could have lots of other interferences that are not even on our radar. Now, Victor Muniz from Roche Diagnostics Brazil, you have the floor. Good afternoon. It's an honor to be with you, Dr. Martha, Vagner, and Dr. Victor. I will base my conversation on two aspects. One is professional and the other is personal. And I have three important messages that I'll be elaborating on and go back to them in the end to provide more context. The first one is that we've been focusing on integrated diagnosis, prevention, and from diagnosis to treatment. That's my first message. And the second is we're always looking for the right treatment for the right patient in the right moment. And the third, and that's from my personal experience, we used to say that genetics is not equivalent to destiny. And that's a very important aspect, but genetic diagnosis could change your destiny. So I want to leave you with these three first comments to start elaborating my message. In terms of the genetic diagnosis, a lot of what we've been doing when it comes to companion diagnostics, it ranges from NGS, which is very well developed by our partners, but it also involves the diagnosis of molecular biology with a PCR. A lot can be learned from an EGFR, KRAS, MRAS test, the diagnosis of HPV for cervical cancer. That is something that we've been working on in terms of giving women access to the HPV test, because it's much more precise and you're able to prevent cancer in patients. And we also work, and Dr. Victor is very experienced in immunohistochemical processes. With PD-L1, we have a targeted therapy that will provide a better response for breast cancer or ALK. So we do all of that as a company, but always in line with prevention and treatment. And in that regard, we've also been working on developing a more ecosystemic perspective, and not only in terms of the lab, but we also work with providers, the C. Camargo Hospital, and we've been making this connection to bring down the total costs of health and improve patient outcomes. So we've been working on this integration. And Roche made the decision as it's the only company in the world that operates in the with diagnosis and advanced pharmaceutics. The other thing that I want to tell you about is about our genetic panels for hereditary cancer. And I want to tell you a personal story, which is very important. In my family, my father died from cancer. My grandmother, my uncles, I have 5 uncles who died from cancer. And being at Roche, I talked to some colleagues, and they said that it would be interesting if we could, if I could look for a geneticist at a hospital and do the test. And I talked to the geneticist, and I scheduled a visit. And I did it because it was really important for me. And much to my surprise, we did the genetic tests, and one of the changes there was this MSH2 alteration, which is connected to a syndrome. Last year, I was weighing 107 kilos, and the doctor told me that I had to immediately lose weight, and I had to do an annual colonoscopy, endoscopy. And that's when I started a diet with medical guidance, and I lost 15 kilos. And that was transformative. And how we work on access and how to select the best person according to family history and in the public system to expand that access. So all that, I think, we focus a lot on the 4P medicine, preventative, predictive, personalized, and participative. So that is my general experience. Well, Martha, in his case, doing having an annual endoscopy is cost effective, and it should be covered. However, other individuals without that alteration, that could be a waste undergoing annual endoscopy. So we have to make progress in that regard and see where genetics can help us make better decisions. And going back to what I mentioned, how to integrate the best diagnosis for the right patient at the right moment. Of course, genetics is not equivalent to destiny, but genetic diagnosis can change your fate. That's my take-home message. Great, Victor. I think you gave me the courage because I have a recommendation, but I'm trying to push it forward. And I'll talk to you, Victor, later on. But I think that we also have to think about the consequences, right? You have to be willing to face the consequences, and you were willing to do that. You lost weight, and you did what had to be done. Anyway, I took note of several things. I think the three things that Muniz talked about are very important. And anyway, now we'll take questions. So I'll leave you with two questions for you to discuss, and in these next 10 minutes. The first one is one thing that we've always discussed in the healthcare system. I'm not a geneticist, and I think that that's my perspective about the health system. And for genetics, we've always talked about reference centers. It will never make sense for you to have everything available everywhere. And these reference centers, they're usually not. They don't even have to be in the country where you live. They can be anywhere in the world, with a view to optimizing your treatment. And as Victor said, doing things correctly. You do not necessarily have to do everything everywhere. So I think I'd like to hear your perspective on this rationale. What's the rationale that we should adopt to allow and to enable everything to be offered within this perspective, which is something that we've always discussed for genetics? And the second thing is, how can we prioritize? I mean, you mentioned something in the end that stood out for me. For us to have not only the perspective of who is going to use it, who is the best patient, where can I locate the correct patients, like Victor said, but as a consequence of that, I also have to have personalized protocols based on that result. And one such example was Victor. He took the test, and he was tested, and then as a consequence, he got a personalized protocol. With cancer, we still have that in a very clear-cut manner. It is the specialty that makes the most use of protocols. But as for the rest, we're quite flawed in terms of the use of protocols in Brazil. And I think my question is, how can we start, since we're talking about something that is about to arrive very strongly? We already think about how to treat before and how to treat after. You have a tool here in the middle, but there's a moment before that that is connected to the diagnosis and so forth, and there's something later, something after that. So I'd like to hear your take on these two comments, and we can follow the same order, starting with Vagner, if you agree. Well, actually, Martha, I think these two comments are connected, because if you talk about reference centers, I agree. You have specialized people who, over the course of their career, they had a lot of contact with that specific type of disease that you want to treat. In addition to that, a reference center, and it's very important when it comes to genomics, it offers a database, because over the course of its existence, it starts accumulating a number of cases connecting a genotype and phenotype, and that makes it easier for algorithms to analyze and determine certain genetic variables. And I think that the main aspect about centers of reference is that they have a highly specialized experts and a database that it amasses over time, which is extremely important for genetics. And to me, these are the two factors that stand out. Of course, that there are other factors that are important, but it's very important for us to have reference centers if you're able to identify that certain diseases have to be referred to a specific center. And that goes back to the aspect that you mentioned about who is the best candidate for a better for a certain test or for a certain treatment type. And I think that takes us back to primary care. And that's something that we still see in genetics, which is education. And we have a shortage of education in genetics. Dr. Victor had the privilege of having a lot of contact with genetics, but many doctors that are also experienced have not had contact with genetics because it's a relatively new science. So we need to work not only with medical school students, but also people who work with primary care at different levels, nurses or whoever it is, so that they are trained to identify a possible candidate and refer them to the right reference center at the right time. And that's something that we see a lot in rare diseases. For rare diseases, it's hard to diagnose or telling a child who is in the autistic spectrum apart from a child with an intellectual impairment. If the primary care is not prepared to identify that child, the journey towards diagnosing that takes too long because the first symptoms will only start showing up when, in theory, that child was supposed to be starting to talk and walk and so forth. And I have children with kids who have not been diagnosed yet, and they're 6 years old because they did not do a complete exome. And our public health system approved the use of a complete exome test for intellectual impairment. But we have to work on primary care and on educating and training professionals that are skilled and to identify these possible disabilities so that we identify the right patient for the right treatment and for the right tests for a more accurate diagnosis and consequently the treatment.
Martha, as to the logic of centralizing or not, I see it as a continuum. Genomics has evolved so quickly. We're coming up with new tests, and you have a bigger and bigger menu of alternatives. It's not the gene we're looking for, but how you look for it. That has changed too. The speed at which these things happen. We won't be able to develop that in any lab separately. There will be some degree of centralization. And then we can standardize, we can test it, we can make sure it's right. And once everything is perfect, we can teach others how to do it. But genetics play a different role. The role of generating knowledge. And once I have that knowledge, I don't have to resort to a genomic test. Immunohistochemistry can help me now, or maybe CPR. So you have those rings of information, those rings of knowledge. What is complex remains in the same place. It's up to a reference center. We're a good example of that here. And then we simplify the methodology, and it will then be used in other places that will be able to replicate methodologies, but not with the necessary conditions to create new protocols. So the speed at which the discipline evolves gets in the way of having that happen in many different places at the same time. So there should be some centralization so that tests can be somewhat standardized. As to personalized protocols, I have very interesting data. Oncogenetics is huge. We monitor over 40,000 families, some families with 80 individuals, but we keep track of every hereditary syndrome. We have come up with the protocols. They're not that complicated. We have to come up with a cost-effective system, but by and large, people that are monitored by oncogenetics, they don't die of cancers because they have that early diagnostic. By adopting those measures that, just like Victor did, they'll take action. So we'll manage the problem. We're not going to be run over by it. For some tumors that may require a full body MRI to determine pancreas mass, soft mass, for those that make sense. But the protocol may be different for other people. So we'll come up to protocols for every hereditary syndrome. And then, Vic, we're talking about highly specialized cases. We need the knowledge to be disseminated so that everyone can resort to this kind of information. I'm fearful as to the way things happen in Brazil. Everything we do here, we end up moving away from the good use. And we use that methodology that will end up harming patients. Genetics is a huge subject. We must focus on training. Training for the entire system, not only one professional, one operator. You have to train the entire system, all the way from primary to tertiary care. That's part of our mission, AC Camargo, to train people. This is in our DNA. We've been doing this from the very foundation of the organization. This is what makes us happy. We must, this is a very complex topic. The speed with which knowledge is discovered. If you stop studying 3 years ago, you're no longer up to date. Things change dramatically very quickly. You have to go back to the university, you have to go to an internship program. The carriers, the providers, the auditors, that information has to move around. Exactly, Victor, you're right. Today, we perform a checklist-oriented audit, and we're moving towards a world in which a checklist audit will no longer exist. I'll be talking about prediction, different models for healthcare, a personalized segment. So there are several things then which there will be that breakthrough. There will be that disruption will take place. That's how we evolve. This is how we move ahead. Friction is what moves progress, what makes things happen. Victor Muniz, over to you. As to having that reference center, I had a personal experience with my dad. My doctor, or his doctor said his case was very complicated. He had there was a board, actually, of doctors ended up working for Roche. We have a solution called Tumor Board. It helps doctors to consolidate several cases, genetic test results, image results, and you can organize the material to come up with that decision. A reference center is important because a doctor may have seen similar cases and they'll have a joint decision that is evidence-based, and there will be that critical mass, just like Dr. Victor said. You had 80 family members. You can come up with more appropriate treatments because you know them better. So there are huge advantages to any reference center. I had something in my nose, and then I go to Dr. Ivan. I want to find out whether they have that experience because they know how to treat that problem once they have that experience. You, as a patient, can feel comfortable that that subject or that provider does have some knowledge, some experience about that subject. Okay, it's in terms of diagnostics, you get a result, for example, but you have to go back to the doctors, get that information, get that orders or the whatever the prescription is, any test or colonoscopy or chemical series, and you have to go to other specialists. How can I lose weight? You just can't check a website. It's important to connect all the elements together. The genetic diagnostics with the geneticist and endocrinologist. So it goes beyond oncology. It's important to connect all these elements together. Health institutions or health providers are looking for that integration. You can no longer have disconnected things. Okay, I run this test, but how can I connect that to the entire patient journey? I like this trend, managing health rather than managing disease. Some healthcare providers will keep track, will monitor your life. That will change the system because we usually resort to a doctor whenever there's a problem. You have to do that before. You have to have that yearly checkup, that routine. You can run regular tests, but if you have a track record, you have to resort to a genetic test, for example. All this can be conceived, can be set up if all players are willing to contribute, to co-create. That's a challenge too, right? How do you integrate all these players? Because in the end, we want the best for the health system and, of course, ultimately for the patient. I know, Martha, we are running out of time, but there's something we haven't touched upon, but it's very important indeed. Patients with the same tumor would get the same drug and will respond differently. The answer may be in the way each individual will metabolize drugs. And the studies we conduct here, some women may need higher or smaller doses depending on how they metabolize the drug to reach the same response. One patient may need one dose, another patient may need twice as much because the way I metabolize will vary. Genetics can explain that too. Just like alcohol metabolism, how you metabolize alcohol. I think we are right in the middle of a phase in which we are acquiring knowledge at lightning speed, but there's still a long way to go, the way I see it. In the years to come, I truly believe when you combine genetics, biosensoring, and predictions or predictors, we're going to have a major breakthrough in the health system. We may end up having a much different system We couldn't even conceive it some years back. Now we can. What would a health system look like? I am monitored all the time. Every signal generates new information that will be combined with my genetic data and my consumption data. Everything connected, whether I exercise or not, how I respond, and then I can predict the likelihood of having something in 3 years' time. So we couldn't conceive this new system. We have just received word that our time is up. What if you were the organizers, the managers of this new health system? What would be your first step? We won't be able to build everything from scratch. What be step one towards this new system? When technology makes sense, it will be there. Rest assured, it will come. There's no regulation to get in the way. Nothing can get in the way. So, okay, we're there. Technology is there. What would you do to better include that in our system? And you can also add that to your closing remarks, please. When I think about the future, I tend to get very creative. When babies are born, you have a complete genome. You know what the likelihoods are. So a drop of blood is enough to detect early signs of cells that have just started mutating. You know what the tissue is. It's cheap. It's a cheap test. This is going to be a very simple test. Very, very cheap. You can do them very often. Of course, we're still a long way from it. We need data to contribute. That's one of those risk score diseases. It's a multi-gene disease or multi-gene dependent disease. And you'll be able to come up with a score to predict the likelihood. We've been talking about CRISPR genes, gene sequencing or editing. The important thing is how to be cost effective when we apply these to our reality. And ethics getting added to the mix as well. In sum, the future is very promising. It involves genomics. All we have to do is wait. I think we'll be able to see the future. We'll see many practical things in the near future. Thank you for having me. Thank you. Very pragmatically, I'd say that there will be 3 parts in this future. We already identified where genomics is cost effective. We must define what the tests are, what we do with them, and how to make them feasible. How do you make them practical to prevent diseases and suffering? A second topic would be learning more and finding new tools. And maybe a third phase further into the future. These studies, these methodologies will be much cheaper and we'll be able to have a large scale. Bringing in information, algorithm, a test we develop here, a test that takes 15 seconds. The difference is that it may be 1 or 600, a machine can run all of them at the same time for the same cost. I can predict that for many people. This will revolutionize the way we work, but the ecosystem has to follow along. Whatever is effective, good for patients, we'll have to come up with a way to offer them to them. That's it, Victor. I have two things to say. Number one, how to manage populational health immediately, how to be brave enough to act preventively, managing health, but also managing disease. We can only reach that goal once you break down the populations by groups. And number two, you have to re-evaluate diagnostics. You have less than 2% of investments in health all over the world, and it can influence all the way up to 70% in doctors' decisions. How do you shift that kind of investment in diagnostics to help put more focus on prevention and personalized and a more participative kind of medicine? Thank you, Martha, Wagner, and Dr. Victor. Thank you very much. This has been way too long. I learned a lot from you. Thank you. Thank you. Thank you very much. I think this was a very interesting panel that will help us understand the future. Thank you. That concludes this panel. Thank you.